Again, I'm Marcy Gallagher with Mountain Pacific Quality Health, and welcome to our 27th session of It's Worth a Shot. Today, we will be presenting on antimicrobial stewardship in long-term care and environmental cleaning and disinfection. Next slide. So as usual, if you have any topics or clinical ideas, please put those into chat or in the evaluation that we'll be sending at the end of the presentation. And if everyone can put their phones on mute unless you're talking, as the session will be recorded as with the others, and we will be sending the recording and slides out after today's session. And again, we continue to meet every Wednesday from 2:30 to 3 Mountain Time. Next slide. And again, just wanting to thank all of our guest speakers, our partners, especially you all who attend these calls and take time out of your day and who continue to support the needs of our long-term care facilities across our region. So now I would like to turn it over to Jenner Minto. Jenner is a clinical assistant professor at the University of Montana Skaggs School of Pharmacy in Missoula, Montana. She completed her PharmD at the University of Montana in 2017, followed by a 2-year residency in infectious disease and academics at the University of Montana. Since 2017, Jenner has worked with the Montana Department of Health and Human Services on an antimicrobial stewardship grant to implement stewardship programs throughout Montana. In addition to her work as a pharmacist. Oh, I'm sorry, I was on mute. Did anybody, did you hear Jenner's intro?
You were in and out on mute.
Okay, I don't know what happened. I will just recap that Jenner is a clinical assistant professor at the University of Montana School of Pharmacy in Missoula. She actually is working with the Montana Department of Health and Human Services on antimicrobial stewardship to implement stewardship programs throughout Montana, and also serves as a pharmacist at Barrett Hospital and Healthcare in Dillon. So my apologies, but I will at this time go ahead and turn it over to you, Jenner. Thank you.
Excellent. Marcy, thank you so much for inviting me to talk today. And as I told Marcy earlier, I'm going to do my best to keep this to 15 minutes, but sometimes I have a tendency to talk. So I'm also very happy to take questions as I go through the slides or at the end, either way. I actually got my start in antimicrobial stewardship. When I started, we were working with the Department of Health and Human Services with the idea of starting antimicrobial stewardship programs in our critical access hospitals. But the first couple of years, we didn't have a whole lot of interest. And so I actually got my start in working with stewardship programs in long-term care. So I'm going to give you a little bit of background, give you some ideas maybe about where to start with long-term care antimicrobial stewardship, and then share some data that we came up with in one of the projects that I did with one of the nursing homes here in Missoula, Montana. Next slide, please. So the CDC has put together a list of core elements of antimicrobial stewardship. These involve leadership, commitment, accountability, drug expertise, action, tracking, reporting, and education. And I'm going to focus primarily on the action, tracking, and reporting components today, because I think those are a really good place for us to get a start and really determine where we can be beneficial in our long-term care facilities. Next slide. So CDC also recommends implementing at least one policy or practice to improve antibiotic use. But when we're starting our antimicrobial stewardship programs, it can get a little bit overwhelming. So a little bit challenging for us to decide, where do we start? How do we determine what policies are important? How do we know what's most relevant for our facility, or for our patient population? So the first thing I would say is planning and organization. So very important early on in your stewardship program development to figure out who is going to be members of your antimicrobial stewardship team. And the CDC has a lot of really good resources as to what team members are important for both long-term care and hospital AMS programs. So I would say, talk with people on your staff. You'll want somebody in a leadership position. You'll want somebody that's involved in infection prevention. You'll want someone that's involved in nursing. If you have a pharmacist available, that's ideal. And then you'll also want someone that is on a medical staff that can take a leadership role as well. So once you've established who your team is going to be, determine what those roles are going to be. Who is going to play what role, so that each individual has their own responsibility and you're not stepping on toes and overlapping and multiple people taking on the same role. So that was a really short introduction on planning an organization. That's obviously something that's not going to happen quite that rapidly, but it can actually develop over a period of time. Start with 1 or 2 people within your organization that are really excited and interested in stewardship, and then build from there. Once we have our team together, we need to figure out what is going to be most beneficial for our particular patient population. Where do we start? And in order to get some of this information, we can't just, take a big picture look and say, we've got an elderly population, we should do some stewardship. Well, what does that mean? Probably want to do some tracking. Go back and look at medical records, look at patient charts, look at prescribing practices, and try and figure out what is the most important. I can say in long-term care, urinary tract infections are always a very safe place to start because they're rampant in long-term care facilities in our older population and often not treated appropriately. Then what I would say is make sure you're having regular stewardship team meetings. So once your roles are defined, you've decided what goals you have, what you want to accomplish, meet at least monthly with that antimicrobial stewardship team and see how you're progressing. How are you coming along? If everybody has one small task that they want to accomplish in a month and everybody is achieving those tasks, you're going to make a lot more progress than meeting once or twice a year and saying, gosh, I'd really like to put together a tracking program so that we will know by the next meeting what our needs are in our facility. And then the next meeting, not have that done. So very specific goals and follow through. Next slide, please. So where do we start with our needs assessment? Monitor at least one process measure of antibiotic use and at least one outcome from antibiotic use at your facility. Again, a recommendation that came from the CDC. I will say that chart review is a very good place to start. Go back and look at the charting that's done on patients that are prescribed antibiotics. Simple things like looking at whether or not the indication is documented. That's something that we actually found missing in a lot of the facilities that I was working with. There's also a days of therapy tracking tool that we use here in Montana. It was actually developed by the Montana Hospital Association as part of our Antimicrobial Stewardship Collaborative. And it is available through the Mountain Pacific Quality Healthcare website. And I believe that has now been updated, so it's our most current tracking tool. So the next couple slides I'm going to show you are some examples of what that tracking tool looks like and how you can use that to get some good information from your patient population. Next slide. So what this is a copy of our updated tracking tool with some de-identified information. This is obviously not information from a long-term care facility, but from a hospital that does have an associated long-term care facility. So essentially what you'll do is for each antibiotic day, you're going to document where the patient was located. And this is easy if you're in long-term care facility because you don't have to worry too much about this step. Where is the patient located? What antibiotic name? So what antibiotic was administered? This antibiotic class, this is going to auto-populate for you. The route of administration, either IV or oral, date first taken and date last taken. Everything else, with the exception of provider on this screen, will auto-populate for you. So if you enter January 1 of 2020 and then January 15 of 2020, this spreadsheet will automatically say, these patients were taking this antibiotic in January, and that's 7 total days of therapy. And days of therapy is the metric we use, and it's actually days of therapy per 1,000 patient days to measure the antibiotic use in an individual facility over a period of time, so that we can compare our antibiotic use not only to our own facility over a period of time, but also to other facilities with similar demographics. And then finally, the prescriber menu, you can add into your own little, I think there's a tab at the bottom, trying to figure out which one it is, and I can't see the bottom of my screen. But you can put them in a drop-down menu and then just drag and drop your providers so that you can track which providers are writing which antibiotics. Yep, the tab says drop-down selections. That's what I was looking for. And next slide, please. Then there's a section off to the right of the spreadsheet that I just showed you. And this is one that, oh goodness, this is not what I intended to have on this slide. I think maybe it's on the next slide. Anyway, this is just a larger cut of that same information that you saw on the last screen. Yep, that was not what I intended to have on there, but I will tell you what I intended to have on there. So off to the right of the information that I showed you on those previous spreadsheets is some additional information that allows you to track culture results. It allows you to track McGeer criteria for patients in long-term care facilities. Do they meet McGeer criteria for treatment of urinary tract infections? What is the duration of symptoms? What do the culture results look like? That's not something that we easily have access to in a lot of our hospitals without going through the charts. But in a long-term care facility, you can get a lot of really good information from that. So if you're interested in this tracking tool, I would definitely recommend that you take a look at that additional section of the spreadsheet as well. Another component of this spreadsheet is simply adding the days present. So how many patients do you have in each individual location in your facility for a given month? So for a long-term care facility, you would just enter your census data for each individual month, and then that will help you calculate the days of therapy. Next slide, please. And this is actually what you will see on one of the final tabs in that spreadsheet. It will calculate and auto-populate for you the days of therapy per 1,000 patient days per month at your facility. And over a period of time, you can track. Now, in this particular facility, we can see that obviously I didn't have any data October, November, and December added, but we can see that antibiotic use was a little bit lower in January, a little bit lower in June than it was in, say, August and March. So it'll allow you to trend, and over a period of years, you can kind of track, you know, do we use more antibiotics during flu season? Do we use more antibiotics in the winter months versus the summer months, et cetera? Next slide. This is what I wanted to have on that previous one. I don't know what I did, so I apologize for that. So this is the little section that allows you to document use by indication. It will allow you to identify individual goals within your facility. If you're seeing a lot of prescriptions for antibiotics that are not indicated, so in this case, specifically urinary symptoms, if you're seeing antibiotics prescribed because there happened to be an incidental urinary culture done or a UA that came back positive while the patient has bacteria in their urine, let's treat this. If there aren't symptoms, if McGeer criteria don't or are not being met, then it really isn't appropriate to be using antibiotics. Next slide. And this next section will, if you fill out that information by indication, this will tell you what antibiotics you're using most commonly and what indications those are being used for. So if you're seeing 90% of your antibiotics being used for urinary tract infections, that's probably a good place to start. If you're seeing that most of your antibiotics are being used for pneumonia, maybe start with looking at pneumonia within your facilities, see whether or not the antibiotics that are being used for those indications actually follow the guidelines and the recommendations for those patient populations. Next slide. So I always recommend to organizations that are just starting, start with very small goals. I had one hospital that I was working with, and we probably spent the first 6 months of their stewardship program just working on making sure that documentation of antibiotic use was available in the notes, because without that documentation, it's really hard to determine whether or not those antibiotics are being used appropriately. So simple education to your providers. If an antibiotic is being used, there needs to be a note that indicates what the antibiotic is, why the antibiotic is being written, and for how long that antibiotic is going to be used. And then looking at things like appropriate lab tests and culture results. So we noticed in the long-term care facilities that I was working with, often we didn't have renal function tests within a year of patients that were receiving antibiotics for urinary tract infections. Really important, especially in the elderly population, that we be able to renally adjust those medications so that they're safe and effective for our patients. Other things like urine wound cultures. Make sure we're looking at what those culture results say. So are we targeting the appropriate organisms? Do we have organisms that have some kind of unique resistance patterns within our facilities? And that's something that I'll talk to you about in the next few slides. But one really interesting finding from the project that I did in the skilled nursing facilities here in Missoula is that our resistance patterns in Missoula were very different from the resistance patterns that were being seen in the long-term care facilities. So baby steps, start with things as simple as, are we documenting antibiotic use? And then go from there. Next slide. So urinary tract infections. I will say this is a really good place to start in most long-term care facilities. One of the most frequent infections in long-term care facilities, and also the most common cause of long-term care acquired bacteremia. Make it a very, very easily identifiable stewardship target. It's not necessarily an easy fix just because it's an easy target and easily identified. But urinary tract infections, I think anybody that works in long-term care for a long enough period of time has seen urinary tract infections and the consequences of those. Next slide, please. So this is a chart of data from one of the nursing homes that I worked with when I started this project in 2017. And what I did was I looked at each individual culture result. I went through all of the patient charts for the urinary tract infections that had been diagnosed and treated over the course of a year. And what I did was I looked at the culture results and looked to see what the susceptibility rates were for the different antibiotics that, one, were routinely used, and two, that had been most commonly used in that particular facility. So what we found here is that the most commonly prescribed antibiotics for urinary tract infections in this individual facility were our fluoroquinolones. Now, our fluoroquinolones are very high risk antibiotics for long-term care patients because the side effect profile is a little bit more severe in our elderly population. So what we were seeing not only is that we are using high risk antibiotics, but if you look at the susceptibility rates, the most common organism we identified was E. coli. And if you look here, the susceptibility to levofloxacin, which is one of the fluoroquinolones, was only 47%. So empirically speaking, before we had a culture result back, less than half of those organisms that were identified were being appropriately treated empirically, which means, we don't know what the organism is yet. We need to give them an antibiotic and do our best to cover that organism. So really what this data showed us is that the antibiotics that were being initially prescribed were not appropriate for initial treatment. We also found that some of our lower risk antibiotics, so our cephalosporins, had fairly high susceptibility rates, as well as our macrobid, which is also fairly safe in our elderly populations. So first line agents, only 33% of our first line agents were being prescribed for antibiotics. Really overwhelmingly, we were seeing prescriptions for fluoroquinolones. And like I said, it turns out that was probably not the most appropriate antibiotic to be using. And this is what I was talking about. If you look at the fluoroquinolone resistance in Missoula overall, you're still looking at susceptibility rates of about 90-some%. But looking here at this individual nursing home, less than 50% susceptibility. So very different than our general population here in town. Next slide. I have gone way over my 15 minutes already. I apologize.
You're okay, Jenner.
Okay, so this is just a sample of some facility-specific treatment recommendations that I put together working with the medical director at this particular long-term care facility. So like I said, the first thing we did was look at whether or not everything was being appropriately documented in the chart. Then what we recommended to the providers was to look at those McGear criteria. If the symptoms are not met, then consider alternative diagnoses. It's not always a urinary tract infection just because there are urinary symptoms. Push fluids. Another finding was that we found most of the patients were fairly dehydrated. And by pushing fluids, it was able to clear that bacteria a little bit without some of the antibiotics. And then monitor daily vital signs. So are the patient's vital signs stable? If they're not stable, we're going to take this a little bit more seriously. We don't want a patient to, wind up hospitalized for a urinary tract infection because 24 hours earlier we didn't treat because they didn't meet McGear criteria. So look at the big picture with the patients. But overall, if they do not meet those criteria, we really don't need to use antibiotics. And then what we did were to define, based on the opinion of the medical director and what we saw as trends in the individual facility, was to define uncomplicated versus complicated infection. And you'll notice that these definitions are a little bit different than what you'll see if you, go online and say define complicated versus uncomplicated urinary tract infection. So these are very facility specific. We also recommended getting a UA and a culture for any patient that was going to be treated with antibiotics. And this was important because, one, we know that we're going to treat the appropriate organism. If we have a patient that we're treating with a fluoroquinolone, but the organism isn't susceptible to fluoroquinolones, the patient gets better in 5 days. The patient probably got better because the infection resolved on its own or because it wasn't truly an infectious process. Also get appropriate blood work. So basic metabolic panel, particularly if there's a consideration to treat with any of our antibiotics that need to be renally dose adjusted. Fluids. Unless your patient is fluid overloaded, the best way to start the process of treating these urinary tract infections is to try and keep your patients well hydrated. Again, daily vital signs. And then once we've taken those culture results, always make sure to have a provider or somebody that's going to check for those culture results daily. And when they come back, make sure that the antibiotic that is being used is actually appropriate for the identified organism. If we have systemic symptoms or pain, definitely going to culture, get our BMP, same as we are before. Anytime we have symptoms, we are going to treat as if the patient has a urinary tract infection. We're going to treat empirically based on the patient history. So depending on what they have been treated with before, do we have a previously identified organism? What are the patient's symptoms? Are they severe enough we need to take them to the hospital, have them admitted for IV antibiotics? Is this a simple infection that we can treat locally? But we are going to treat empirically with any kinds of symptoms. Next slide. I think that was the end of my slides for you. Just a couple pieces of information that might be helpful. The core elements of antimicrobial stewardship for nursing homes, and then the Montana Antimicrobial Stewardship resources available to you at the Mountain Pacific Quality Health website, which are fantastic. And thank you so much to Mountain Pacific Quality Health for allowing us to post some of our resources there. This is where you should be able to find that tracking tool that I mentioned.
Wow, thanks, Jenner. Lots of great information. Does anybody have any questions for Jenner, or if you wanted to chat those in or come off mute?
I apologize. I didn't realize my camera was off this whole time.
No worries.
And I'm happy to take questions. I also included my email in chat if you have any questions that come up later or you'd like to reach me for any reason.
Well, thanks again. That was a great presentation. And go ahead. Did somebody have a question?
Just a comment more so. Thank you for the specific examples on where to start. You might say we're doing a reboot type situation with staffing changes and so forth. And some specific start here was very helpful. Thank you.
Great feedback. Thank you.
Hi, Jenner. This is Jessie with Mountain Pacific. I have a quick question for you.
Go ahead.
You said that it was identified that there was different resistance in Missoula. What do you mean by that compared to other areas?
Right. So there'll be different resistance patterns. If you look at which antibiotics can be most appropriately used or most safely used in one location versus another. Montana being, not very populous, we have fairly low resistance. So most of our antibiotics still cover most of the organisms that we see. Whereas if you were to look at a large metropolitan area like Chicago or San Francisco, you're probably going to see a lot more resistance. But what I'm talking about here in Missoula is we look at overall what antibiotics are still able to be used for each individual organism. And we put together antibiograms for each hospital. Most hospitals in the state will have an individual antibiogram. So I had resistance data from both of the hospitals here in Missoula. And what I did was then I went through and I looked at the individual culture results within the nursing home. And what I found is that there were much more resistant strains of E. coli, particularly within the nursing home, than what we're seeing in the general population in Missoula. And there are numerous reasons for that. Obviously, if there's direct transmission, that's possible. It's also possible that these patients had been treated with the same antibiotics repeatedly enough that resistance had been developing to these antibiotics. So essentially what I'm saying is you can't safely and effectively use the same antibiotics in your general population that we could in these individual nursing homes.
Thank you. Thanks.
Any other questions for Jenner?
Marcy said 15 minutes and I took 28.
Hey, it was an excellent presentation. So again, thank you, Jenner. And we will send these slides and probably even attach that Days of Therapy tool. I noticed it's not up on our website, but it's due up today. So we will get that posted, and that's where you'll be able to find that tool. So thank you for sharing. And please, everyone, don't forget to complete the evaluation link that is in the chat. And we will give you back 1 minute of your time, and we will catch up with Crystal Morris at another session for the environmental cleaning and disinfection. So everybody have a great rest of the week. And Jenner, again, thank you so much.
You're welcome.